Hello guys, how are you? Hope you're doing good. Uh, I've been constantly improving, changing that. I had a comment of that the video quality is not good. This time I've changed the video quality, used a different camera, external camera. Hopefully that looks better. Previous day I was using the Max webcam, and if it's better, do comment below so that if it is good, I'll keep doing the same thing. And if there is any disturbances, let me know that we'll try to change something and make sure that it ends up productively. Fine. So these are the few things here. The Plus subscription. If you're interested in Plus subscription, use the code PathoCups. If you want to anything, if it's not affordable or anything, do let me know. I'll talk to the management and we'll see what best we can do for you guys. Fine. And iconic subscription comes with the Unacademy Plus prep ladder. That would have been good if you want more than one educator teaching you guys. But because Unacademy is more popular in the live session, and the recorded ones will be there in prep ladder as well. And there are few plans, limited period of it. This particularly I will be interested if I'm a second year student. If you're a second year student listening to this would be do good because it's a four years. Both prep ladder as well as Unacademy for 75,000 is a very economical deal. I wish I had something like this during my time, right? So you can attend all 4 years live classes with all the educators, whatever subject you want. Like if you're in second year, just limit to that subject. Third year, limit to that subject. Do the prep ladder MCQs. All the MCQ versions 2, 3, whatever has been upgraded will be given to you guys, right? And raise hand option has been there in Unacademy Live in the app. That is a thing which makes it feel like a normal classroom teaching. Like you sit in a classroom, you cannot do this in 1,000 audience, but definitely you can do this in your college, right? The tutor asks you a question and you can just answer by thing, right? That might be try to implement all those things. This I'm pretty much interested, which will be launching on 30th June. Where all of you guys of these era are being perplexed that how do I integrate chapters. Some of you sought to UWorld, the USMLE bank, to study about it. Here what we're going to do is we're going to replicate the same thing. If let's say that if we're discussing about kidney, I'll be coming and talking about your renal pathology, someone for renal physiology, someone for renal medicine, and the drugs used. So it's going to be a vertical integration. If you have a good amount of time, enough amount of time, this will be the best way to read, and you will definitely understand the concepts in depth because I'm having an integration all throughout, right? And few more things. You can use whatever code you want, right? It doesn't matter. If you can use your PathoCups also, I'll be more than happy as well. Hello doctor, hello. Fine. So what you're going to do is we are going to continue this same WBC. Few questions which I discussed in the morning. I just wanted to recap a few newer topics of HLH we discussed in the morning. I just want to have a quick recap of the same. So if that happens, let's see that how many of you can retain whatever we learned new, right? So listen to this question, this answer. If you're new here, if you're not seeing the question previously, do let me know the answer. 2-year-old previously admitted for fever and confusion. That's my primary complaint, right? Tachycardic, hypotensive. On physical examination, jaundice, adenopathy, bruising is there. Lab works reveals pancytopenia. That's my first clue there, right? After that, intrinsic liver injury and acute renal failure. Some end organ damage is also there. Bone marrow is more important, shows giant macrophages engulfing every healthy lineage. Very important. This, with the clinical history, is going to be of major concern for me. If I see just hemophagocytosis, I'm not worried about it. With a clinical history as of major concern, and the diagnostic criteria is going to be 5 of 8. We saw this today morning in the app. If you have not seen it, please go to it. We have an INI-CET Hematology revision session going on. We have discussed everything there. I'll just go through a quick recap of whatever we saw. We saw two things in the morning. We saw about pathogenesis as well as we saw about the criterias, right? So what we saw in the pathogenesis for HLHs, primary or secondary, whatever it is, an unknown etiology, or an HLH with unknown like an viral etiology or a trauma or surgery, something of that sort, right? So when you come to pathogenesis, if it's primary or secondary HLH, doesn't matter. Both of them is going to activate CD4 lineage, activate more activation of macrophages. One of the older terminologies of this is macrophage activation syndrome. Now we have kind of divided a thin line of difference between macrophage activation syndrome and HLH. When you see HLH, hemophago lymphohistiocytosis, right? That's what HLH means. Again, I'm having histiocytes. Histiocytes is nothing but the other name for macrophages. Macrophages are getting overtly activated, and two guys will be low. One is NK cell and other one will be CD8. These are going to be less suppressed, and I'm going to have more activation of macrophages and CD4. When this happens, CD4, it's going to again link with macrophages, produce more and more cytokines, right? And macrophage, activated macrophage again produces cytokines. All these cytokines cause one person. That's my first criteria, fever, right? First criteria is going to be fever. Second, on clinical examination, you will have a splenomegaly. That's again a second criteria. Why splenomegaly is very important is, if I have an aplastic anemia as a DD of pancytopenia, that I will not have a splenomegaly. Here I'm going to have a splenomegaly, right? That's my second criteria. Then this CD4 and macrophages is going to kind of, the cytokines from them, right? The cytokines from them will have other effects apart from fever as well. One of the effects is reduction of lipoprotein lipase. When lipoprotein lipase is reduced, what's going to happen is, third, I'm going to have increase in triglycerides level, right? That will be there, one. Same thing, again, cytokines can also increase your levels of activation of your plasminogen activator, which results in your activation of fibrinogen, the clotting cascade, and you'll have low fibrinogen, which might result in your DIC. Okay, there'll be low fibrinogen, again, one of the criteria. Four, what's given in the question? Cytopenias, right? You'll have cytopenias as well. That's also one of the important criteria. I'm just running through fast because we have discussed them in detail in the previous question, right? You'll have cytopenias, and then you'll have your ferritin, acute phase reactants, which should be elevated, right? All these five. I'm not writing the other three because this is important for me because these are easily available in our labs, right? And the sixth one, the hemophagocytosis in the bone marrow, lymph node or spleen, and two rare ones which is not possible to do it in every setting: reduced NK T cell activity and your CD25 levels. CD25 tells me the CD4 activation. That's a marker for CD4 activation, right? This is what we saw in the morning. I just ran through it because this might be a new topic for some of you guys, so you should not miss any question if at all it comes from these. Fine, okay. Now we'll go to new questions. A few questions which we are going to discuss today. Same on WBC. This we saw today morning as well. This we saw yesterday as well. I'm just going to go to new questions. Just a second. Yeah. Come on, let's start. So now you're going to answer the question. A 65-year-old female comes to the clinic for a follow-up visit. She was diagnosed to have a plasmablastic lymphoma. So this is the question we are going to target on, right? Plasmablastic lymphoma started on chemotherapy with an R-epoch regimen. Rituximab, etoposide, prednisolone and everything was given. Completed 4 cycles of chemotherapy. The question is, which of the viruses is implicated in the pathogenesis or the etiopathogenesis of a plasmablastic lymphoma? So it's a question about plasmablastic lymphoma, right? Do you know any viruses which is involved in plasmablastic lymphoma? Any guesses? Plasmablastic lymphoma might be a new topic for you guys, because whenever you see a plasmablastic lymphoma patient, one thing every doctor is going to ask for is HIV testing. Plasmablastic lymphomas are almost always seen in HIV positive individual, right? Not EBV. But good guess, because most of the lymphomas are linked with EBV. Plasmablastic lymphomas is almost always positive for HIV. Unknown for HIV is rare, right? HIV negative plasmablastic lymphoma doesn't exist, right? HIV will be positive. I'm just writing approximately 100% because nothing can be 100% in medicine. So approximately 100% of the cases will be positive. HIV negative plasmablastic lymphoma is almost not known, right? So do remember it. It's one of the rare neoplasms seen in HIV positive patient. Because in HIV positive patient, you can have lots of lymphomas, lots of other neoplasms as well. This contributes up to, let's say, 2% of the neoplasms which can come in HIV positive persons, right? Next, we'll dissect the name again as we used to do. It's plasmablastic lymphoma, right? It's plasmablastic lymphoma. So when you have plasmablastic lymphoma, the origin of this is entirely not known, because here I am seeing two lineages. What are the two lineages you see here? One is obviously the plasma cell, right? Other one is, I'm calling it lymphoma, presenting with lymphadenopathy. So I'm going to think of a lymphoid neoplasm as well, right? Lymphocytes. So it's a plasmablastic lineage. So here my origin is still in query. They are still discussing about the origin, not yet sure about the origin. But what they do say is, in microscopy, I'm going to have plasma cells, with plasmablastic morphology. Blast means a very immature cell, right? I'll have a plasmablastic morphology plus I'll have lymphocytes. Okay, I'll have lymphocytes as well. Now we have to discuss about the immunohistochemistry. It's an NHL only. Almost every lymphoma is diagnosed by IHC. So I'm having two cells, but I'm primarily naming them as plasmablastic morphology, right? So plasma cell, it's germinal center, pre-germinal center or post-germinal center. We'll go back to the basics. Plasma cell is perfect. It is an post-germinal center cell, right? It arises from post-germinal center. If I have a normal plasma cell, right, just a normal plasma cell, are they positive for standard B cell markers or they are positive for any other new markers? A normal plasma cell. Not always they are positive for standard B cell markers, but they are positive for few more markers, right? What are the few more markers which you know? The few more markers which you know is CD38, CD138. So I'm going to have positivity for that, right? So we understood the microscopy with the same finding of your name, plasmablastic morphology plus lymphocytes, and IHC of plasma cell lymphoma, they are positive for CD79A. See, CD79A, Sai Kalyan, CD16 and CD56 are not, yeah, perfect. I think you deleted it. It's an NK cell marker. 138, like you guys said, is in plasma cell marker, right? They are positive for CD79A. This is just to say it's in B cell origin. It's a normal B cell marker, right? And since they are post-germinal center, CD38 they are positive, CD138 they are positive. These are to say it's a plasma cell marker, right? It's a plasma cell marker. Perfect. One more important thing. If I tell you, tell me germinal center markers, what will you tell? Whatever comes to your mind. Tell me whatever comes to your mind. Markers for germinal center. I'm sure you will at least remember one person. CD10, right? CD10, BCL6 are germinal center markers. Like that, I have something for post-germinal center. I have very specific markers for post-germinal center. What are they? These are post-germinal center markers. I have discussed this once in the B cell journey. We'll again relook it later on. Post-germinal center marker is IRF4, MUM1, right? Do remember this along with your germinal center. TDT might not be germinal center marker, right? Germinal center is B cell, little bit of maturity. So CD10 and BCL6 are primarily the germinal center markers. BCL2 wishy-washy here and there. So I don't put it exactly as a germinal center marker, but 10 and BCL6 will be positive for throughout the stages of germinal center, right? Okay. These are post-germinal center marker. So suspected origin is post-germinal center because of plasma cells. Since I wrote origin is unknown because it has both plasma cells and lymphocyte which are also neoplastic. So both in the thing, so generally unknown, right? So these are the markers you're positive for. Okay. They will be negative for the classical B cell markers CD19 and CD20. Okay, they'll be negative for classical B cell markers. Though it is a B cell lymphoma, they're going to be negative for classical B cell markers. Important. It's very, very important. One AIMS question which came previously also was asked on the same premises. Most of them missed that question. Have you heard of something called as a primary effusion lymphoma? Anything called as primary effusion lymphoma? Have you heard of anything called as a primary effusion lymphoma? This was asked in one of the AIMS exam previously. Again, a new question. Right? This primary effusion lymphoma is also associated with which infection? Again, they are more commonly seen in HIV positive persons. They are more commonly seen with the HHV8 and HIV positivity, right? Perfect. They are again associated with HHV8, your Kaposi sarcoma virus, and along with HIV positivity. Kaposi sarcoma virus definitely is associated with an immunocompromised state. So HIV goes without saying, though HHV8 is considered main to be the pathogenesis. It's called primary effusion. The name itself says your clinical findings. I might not have lymphadenopathy. A patient might not have lymphadenopathy. But what could be the presentation? A massive pleural effusion, a massive pericardial effusion, right? That's one reason if you evaluated a patient of pleural effusion in your wards, they would have asked for cell cytology as well. Not only your LDH levels for the Lights criteria, the protein and everything, also for cell cytology. If it is a neoplastic thing, only a cell cytology will help it, right? So they are going to present as effusion, pleural pericardial. Lymph nodes are rare. I am not saying they will not be there. They might be there, but lymph node enlargements are rare. Again, here also the mistake was made. These are also B cell neoplasms coming from post-germinal center, right? Post-germinal center. Again, they are not positive for B cell markers, not positive for the classical B cell markers. Again, these are negative for CD1920. These are again positive for CD38-138. This CD marker was the question which was asked, I think so. Again, they are post-germinal center origin, positive for CD38-138. Good DR, you remembered it. Fine. That helps us. We have covered two neoplasms, bit of a rare neoplasms. Both are B cell neoplasms, negative for B cell markers. Anything like this, an outlier, I don't know why entrance examiners like them, but most of the time outliers becomes a mark deciding thing. If you read something new in your exam, you're sitting in exam and something a new question, don't go with your conventional thought. Okay, like this. There might be a trap there, right? Just read the question once or twice, mark it, review it later, and maybe you will be able to write the correct answer, right? That's about one question. We'll go to the next question. Okay, I'll read along with you. We don't have a poll option here, so we'll have to read and then let me know the answer. A 58-year-old with a known history of Helicobacter pylori, present with complaints of weight loss. So first clue for me is this. So since we are in neoplasm, I'm going to think of an maltoma of that cause, because H. pylori, only lymphoma which can be related to is maltoma, right? Complaints of weight loss and abdominal fullness. Status symptoms ongoing for the past 2 months. Almost lost 20 pounds in weight. That's 10 kg over the course. The lesion was diagnosed to be a primary gastric lymphoma. Great, whatever we guessed is correct. Diffuse large, further characterized to be DLBCL. Fine. Maltoma of DLBCL is a low-grade maltoma. Over the period of time, can progress to DLBCL. That's that for any lymphoma, right? Prognostication was done further. Alkaline phosphatase, everything was done. She stated that half of the day goes in the bed, completely bedbound and everything. The patient is put on R-CHOP regimen. Which are the following is a bad prognostic factor in a case, right? Okay. So we are going to discuss about the prognostic factors of a maltoma. We must have discussed about prognostic factors of Hodgkin's lymphoma, leukemias much in detail. But for prognostic factors varies between every now and then between every lymphoma, right? And it keeps on updating as well. I just took it so that we have to know a little bit about the prognostic factors of maltoma. We'll go with a normal ideology. We'll read the options. Age, involvement of, I think this must be some, I'll just write spleen, okay? No extranodal involvement other than stomach. Normal lactate dehydrogenase, right? We'll just Upsana HPV negative, yes, fine. We'll look at this findings now, fine. We'll ignore that. We have only 4 options here. Normal LDH. If LDH is elevated, what does LDH tell in a cancer? If LDH is elevated, what does it tell in a cancer? The cancer is big or small? LDH almost always equates to the tumor load, right? So this is not. When I have a normal LDH, I'm not going to think of an bad, very huge cancer. If LDH is high, definitely I'm going to think of something else. No extranodal involvement, fine. No extranodal involvement, only limited to stomach, I'm going to be a little bit more happier, right? Again, that's not a bad prognostic sign. So I'm stuck with 2 guys. One is age, other one is involvement of spleen. Okay, I'm stuck with 2 things, age and involvement of spleen. Most of you have gone with age, right? Let's assume like this. I'm just giving you a clinical scenario. You tell me which is bad. A 45-year-old person, okay, 45-year-old person having a lymphoma which is spread to his spleen, a stomach gastric lymphoma spread to the spleen or spread to the bone marrow, versus a 52-year-old person with lymphoma limited to the GIT. Which is better? Limited to GIT or which is spread outside? I just put the age as 45 and 52 because we have a cutoff of 50 here. Definitely, whatever is limited to GIT is better. Whatever is went to spleen is bad. You guys said that went to spleen is bad. When it goes beyond, the stage changes. definitely age becomes less important for me, right? Age becomes less important for me. So the worst thing will be involvement of spleen. Age, yes, 60 years, right? I'll tell you the prognostication factors. Age is an important criteria, but if it goes beyond 60 years, we cannot do most of the transplantations, most of the chemotherapy will be limited. So we will go for palliative approach generally, fine? So bad prognostic signs for GI lymphoma, this most of the time holds true for every GI lymphoma, whether it is DLBCL in the stomach or in the small intestine and everything. Maybe slight variation will be there, right? Age greater than 60 years, stage 3 or 4 of Ann Arbor. Where have we read Ann Arbor? Which lymphoma we read about Ann Arbor? Extensively. We must have read that in Hodgkin's lymphoma, right? That can be used for non-Hodgkin's lymphoma as well, right? Third and fourth stage of Ann Arbor means, what is third stage? Involvement of sites above and below the diaphragm, right? Involvement of states above and below diaphragm, which means again it is spread, that's all. And 4 is extranodal sites, bone marrow, that also, right? Distant spread. Okay. Both of them is going to be bad for us. Definitely what we are thinking is bigger disease, huge load of the disease. Okay. Then serum LDH elevated, right? Elevated serum LDH, bad. More elevation, more bad. 2 times normal, definitely worse. 10 times normal, definitely worse. Elevated LDH means, because LDH is going to mimic it's going to tell to us about the tumor burden, right? And elevated LDH, definitely it's going to be bad for us. Okay. Okay. Next, more than one extranodal site involvement, again bad. This irrespective of Ann Arbor, right? Anything, let it be below the diaphragm only. If liver is involved, bad. If spleen is involved, bad. Any extranodal site involvement is bad. Okay, could be liver, lung, spleen, etc. Okay, all of these are bad prognostic signs for a GI lymphoma. We must not discuss much about GI lymphoma. If anything is asked, must be better, because almost every lymphoma has been covered in AIIMS exam. So if they have to ask a new question, they're going to go for something new, right? That's what is going to differentiate. Maybe if you know something new, it will be better always. Doesn't matter if it doesn't come in MCQ. Knowledge is going to stay with you forever. Fine. We'll go to the next question. If you have any doubt in this question, let me know. Okay. I'll read the question along with you. A 69-year-old man presented with intermittent right-sided abdomen pain for a month. Physical examination, palpable mass in the right upper quadrant with tenderness. Okay. WBC count of 9,500 for perfect. Hemoglobin, LDH. CT abdomen shows an multiple mass in the spleen, liver with extensive para-aortic retroperitoneal lymphadenopathy. The largest lymph node measured 4 into 4. What is the most appropriate step diagnostic workup in this person? I don't have any microscopic finding. With this clinical scenario, what is your first clinical diagnosis? See, everything is based on your clinical diagnosis, right? Because I don't have any microscopy, I don't have any clue. The only thing is LDH is elevated. LDH about, let's assume like this, about 250 LDH is abnormal, right? We have a range, keep like that, about 250 LDH is abnormal. So tell me your clinical diagnosis, everything is based on that. Is it leukemia, is it lymphoma, what it is? My first clinical diagnosis here is going to be an NHL. The reason why NHL is Hodgkin's lymphoma, abdomen and pelvis, first it is rare. Cervical lymph node validation testing is where I see them more commonly. I'm not saying I won't see in abdomen and pelvis. With involvement of liver and spleen, Hodgkin's lymphoma is rare. Leukemia, unlikely, because the presentation is your normal solid lymphoid presentation, right? So my preliminary diagnosis NHL. So what I'm going to do is I will take the largest lymph node. I'll take an lymph node biopsy. Why not a liver biopsy? Because it says that liver, there is an extensive involvement. You have to answer that. Why should we not take a liver biopsy? Why should we not do a liver biopsy? That's important for us as well. Liver biopsy is not done for the only reason ease. One is ease of it. I'm having a 4x4 lymph node. I'm going to take that lymph node. I'll have a perfect architecture because diagnosis is based on that. If it is liver, I'll have to take a true cut. The tissue will be less. Chance of doing an IHC will be less. Chance for me to do a genetics will be less. And liver is a risky procedure as well. Chance of bleeding is there, right? So because of all of that, I'm going to take the primary site. I'm not going to take a site which has been spread, right? If that is the only accessible thing, perfect. I'm going to take that. I have a lymph node, fair enough. I'm going to take it, right? The primary origin is always recommended, okay? MRI and pelvis might help to look at the extent of the disease. Rather than MRI, I would recommend a PET scan. PET scan will tell me the activity, not just the lymph node size, right? This will be the answer. Where do you require this? I don't require this for this NHL at least. Where do you require this? In which case, lumbar puncture and CSF study is almost mandatory. Perfect, right? For an ALL. Almost all cases of ALL require a CSF analysis. Positive, treat it. Negative, don't do anything. Fine. ALL is where my lumbar puncture and CSF study is required. But for Hodgkin's lymphoma, NHL, any lymphomas, you have to do a lumbar puncture if, very important, if the patient has a headache. Persistent headache. You will not have any other symptom. Nothing else will be there. Persistent headache. If the patient is complaining persistently, I'm having a low grade headache or a severe headache, whatever it is, suspect a CNS disease. Please do a workup. Don't say that NHL will not go to the brain. Right? Textbooks are for us, not for the tumor. It can go anywhere. Wherever there are channels, it will go there. Right? If you have a persistent headache in any patient whom you are treating, even if it is not ALL, ALL is mandatory. Here, based on the symptoms, I am going to investigate. Right? So we are going to do a lymph node excision biopsy. That will be an answer, like most of you had said. Okay, great. Okay, go to the next question. Okay, this might have been a new thing. It's a bit difficult. Just put it for you so that you'll know a little bit about this entity as well. Fine. Let's read the question. I'll read it together. I'll answer. Okay. A 40-year-old male presents to the dermatology clinic for a red-brown papillary nodular lesion. Diagnosis of lymphomatoid polyposis is made after the biopsy, right? I've given you the diagnosis as well. It's a lymphomatoid polyposis. Lymphomatoid polyposis is characterized by multiple histological subtypes. There are 3 subtypes, type A, B, and C. That's not required for you guys. We'll come to the lymphomatoid papulosis now. Just a second. Okay. Type A has an histological overlap with which of these conditions? Fine. That's the question here. We're going to read about something called lymphomatoid papulosis. And there are 3 types. It has an histological overlap between which of the following conditions. In this, I'm sure you have read of these 2 conditions, mycosis fungoides and Sézary syndrome. We know it, right? We know it, fine. And these 2 are a bit new for us. And this question is also a bit new for us, right? We'll make a guess, it's fine. Lymphomatoid papulosis type A mimics and pityriasis lichenoids. That's the answer. Totally a new topic. I just want to cover lymphomatoid polyposis, so I included that, fine. It will not mimic any of the rest, okay? We have something called as lymphomatoid papulosis. I'll just detour. I'll ask you a question. You have to answer. Lymphomatoid polyposis. Which neoplasm is called as a lymphomatoid polyposis? Papulosis and polyposis are totally different. We have one NHL where we call them lymphomatoid polyposis. I'm sure you know that. It's a common NHL which we all read. Not CLL, something related to CLL. It happens in the GIT, which presents as a polyp. Mantle cell lymphoma is also called as lymphomatoid polyposis, right? Do you remember this? Because they present as polyps in the GIT. Rarely a lymphoma will present as polyps. Generally, epithelial lesion will present as polyps, right? It's mantle cell lymphoma. It's in polyposis. It's mantle cell lymphoma, right? Mantle cell lymphoma presents as a polyp, so I'm going to call it a lymphomatoid polyposis. Okay, we'll just discuss about lymphomatoid papulosis. Both are totally different condition. This is in GIT. Lymphomatoid papulosis is a skin-related neoplasm, right? It's a non-aggressive neoplasm, a little bit slow-growing neoplasm. One question which might come is, it's T-cell neoplasm. Most of the neoplasms which involve the skin are T-cell neoplasms, right? Most of them. One neoplasm which you know which involves the skin is your Sécharie syndrome, mycosis fungoides, that group, right? T-cell neoplasm. Most of them will be T-cell neoplasm. B-cell neoplasm is possible, but generally a T-cell neoplasm. Do remember that as a clue. Okay. Fine. This is one neoplasm which can spontaneously regress. Spontaneous regression is known in this neoplasm. Do you know any other neoplasm with spontaneous regression? That was asked in an MCQ before. At least one of them. If you answer one of them, that will be more than enough. Any other neoplasm with spontaneous regression? One of the neoplasm with spontaneous regression is melanoma. It was asked once, don't forget, fine? This also has spontaneous regression, okay? It's supposed to be etiology is supposed to be in viral etiology, Epstein-Barr virus, and other herpes group of virus, yeah, neuroblastoma as well. Herpes group virus is implicated in the etiology of this, okay? Maltoma, I would say, it requires an antibiotic therapy. If with antibiotic therapy, it will regress. Melanoma, without doing anything also, sometimes it regresses, okay? When we come to lymphomatoid polyposis, microscopy, three types of histology, type A, B, and C. What we see in microscopy is, I'm not going to go with what is type A, B, and C. What we see in microscopy, general microscopy of lymphomatoid polyposis, you will have atypical, both superficial and deep. The location is very important here. Perivascular lymphocytes. They should be atypical and these should be CD30 positive. Okay, it's CD30 positive. I'll just tell why type A, that is asked in the question. Type A is a little bit of more eosinophils as well as more neutrophils. Rather than just not only the atypical lymphocyte, they do have eosinophils and more lymphocytes as well. So it mimics an pityriasis lichenoids, that's all. Fine. This is just for a new question. We'll just go through it superficially. Along with the above, CD30 positive atypical lymphocyte, you will see eosinophils and neutrophils. So because of this, it mimics your pityriasis. Okay, it mimics your pityriasis. Okay, but the easiest way to differentiate pityriasis lichenoids and a lymphomatoid papulosis, if I have to differentiate between a non-neoplastic condition and a neoplastic condition, what will you go through? Just one finding. Non-neoplastic versus neoplastic. One thing, atypia. If it's pityriasis lichenoids, I will not have an atypia, right? There will be no atypia. I'm going to go with an just a normal looking lymphocytes, no atypia, not CD30 positive. I'm going to call it pityriasis lichenoids plus the clinical feature as well. And if it is not that, I'm going to call it an lymphomatoid papulosis. A new neoplasm which you read, one of them, it mimics in pityriasis lichenoids. Fine. Might have been totally new, out of the books. See, take this from me like any exam, not only your INI-CET, NEET PG, any competitive exam you write, 4 to 5% of them will be totally new. Definitely, at least there will be minimum 10 questions in a NEET exam of 200 questions you might have not even heard about. Ideal thing is, I would say, don't attempt that question in an exam. Here it's a learning purpose, that's totally different. In an exam, don't attempt that. The reason why I'm saying this is the chance of negative marking is more. Don't be overconfident and attempt them, ignore them, right? Totally new, I have not heard the question, you have to ignore. It's fine to ignore, but don't keep on ignoring most of them like that. Maximum 5%, fine? Okay, next question. Okay, I'll read with you guys. 16-year-old presents with asymptomatic swelling on the right side of the neck for 6 months. He also has complaints of fever, night sweats, and significant weight loss during this period. Vital signs are normal except for temperature. Temperature is a little bit higher. Submental lymph nodes rubbery consistency and all this other so and so finding. Malignant cells resembling outside appearance in the background of scant lymphocytic infiltration. What's your diagnosis? That's enough for us for diagnosis. We have an Hodgkin's lymphoma. It's just positive for CD15 and 30. Definitely Hodgkin's lymphoma. What's the most appropriate next step in the management? I have diagnosed in a Hodgkin's lymphoma involving this area. What's your most important next step in the management? Always before treating, keep this in mind not only for Hodgkin's, for any tumor, always before treating, no treatment first. Never go and treat the lymphoma first. Always before treating, stage the tumor. You have to stage the tumor, right? Staging is very, very important. Again, not B, staging is very, very important. Before treatment, we have to stage the tumor. This is not only here, for almost everything, right? For almost everything you have to stage tumor. Lung cancer, before treatment you have to stage the tumor, right? Hodgkin's lymphoma can involve different parts of the body, can go below the diaphragm as well, can involve my bone marrow as well. This is an old concept. I am not going to do bone marrow biopsy for Hodgkin's lymphoma to look for bone marrow involvement. The easiest one to look for spread is PET scan. PET is ideal. PET is done for almost every cancer. Lung cancer, PET. Almost every cancer we do a PET to see the extent of involvement. See, because let's assume that Akshay, it's useful for management, patient management. That's a primary goal, right? Patient management, if you know that, every exam is going to be a piece of cake for you guys, right? Let's assume you have a lung cancer. You are going to do PET because let's say that I'm having a lung cancer with brain metastasis, or let's say a gastric cancer with brain metastasis. It makes it stage 4. Do you do surgery for stage 4 cancer, or you go for palliative chemotherapy? A stage 4 solid organ malignancy. Surgery, primary or palliative? We generally prefer palliative management, right? So when it's going to be stage 4, which I cannot do in a clinical examination, PET becomes ideal, right? I should have PET, I should stage, then plan management. Staging is important first, then plan your management. Based on that stage, you have to plan your management. Before that, you have to tell the patient, see, you have a stage 4 thing. Your prognosis is going to be very dismal. Very, very important. Plan your management. After planning, just don't give the treatment. There's one of the bad things which you have to let go from the previous generation. When I was an intern, there are lots of HODs of mine, unfortunately, who will say that if a patient asks a question, they'll not answer. They'll say, see, take this drug I'm giving, I'm a doctor, take this. No, it's an informed consent. If it is my body, I would want my doctor to tell me whatever he or she is doing. The same thing we are going to follow for every fellow human being. I'm going to say, see, you have become stage 4. I'm going to give you chemotherapy. Prognosis is 6 months or 1 year based on what tumor it is. Chemotherapy will have its own side effect. Do you want chemo? You don't want chemo. If the patient says, yes, I want chemo, give. If the patient says, no, I don't want chemo or anything, give morphine for pain management. Send us to pain management clinic. Let him take care of everything. Fine? Yeah. For lymphoma, yes, cytogenetics becomes important. For lung cancer, it becomes important. Gastric cancer, not much, right? For few places, cytogenetics and genetics also becomes a role. That's also required before treatment, right? Okay, here the answer is going to be PET scan. Bone marrow biopsy is not indicated in Hodgkin's lymphoma workup. Previously, we are doing bone marrow biopsy. Now it is not indicated. Fine. Okay. That's for today's class. If you have any doubts, do let me know. We'll be having a search path section, second session on gastric cancer today by 8 o'clock in the Unacademy app. You can log in and let's discuss more about gastric cancer. If you want any other integrated session with any of other fellow educators, do let me know, because I personally believe that when I was in postgraduate, I learnt a lot in tumor boards. When I had 4 or 5 people sitting together and all 4 or 5 people teaching me, my understanding of the subject became better. Integrated session is for that. Your understanding will be better. Don't look for MCQ points there. Don't look for your high yield points there. Integrated session is just for your understanding of the thing. Fine. Yes, Ashwati, we'll be having every day around 7 p.m. here on YouTube, and 8 p.m. we'll be having on the Unacademy app, and 11 a.m. on Unacademy app. So 11 a.m. and 8 p.m. I'll be there on the app daily, and 7 p.m. I'll be there on YouTube daily. Fine. Siddharth, I am there on the app. Ranjith, the name will be Ranjith. Initials will not be there. Fine. Just go through it. I hope you will find me. If not, text me. I'll give you the link. Okay. Thank you guys. Thank you for watching. See you soon in the app. Bye bye.